Okay, I've been given the go-ahead to start my presentation. So I'm going to talk about polyunsaturated fatty acids, their lipid mediated derivatives in COVID-19. So this is really, I think, again, a higher level introduction to the talks that Charlie, Bill, and Adam will give around fatty acids and their lipid mediators. So this figure captures the idea that I talked about in the introduction of this coexisting state of hyperinflammation and immunosuppression, which makes a patient susceptible to poor outcome, makes them susceptible to tissue injury, to organ failure, to loss of immune defenses, and predisposition to secondary infections. This was drawn using something like a surgical insult, but of course, with a patient with COVID-19, by the time they're hospitalized, they're already somewhere along the path here, perhaps moving into this hyperinflamed immunosuppressed state. Now, if we look at the fatty acids present in the membranes of these cells, so if we do a fatty acid composition analysis, these are cells from healthy volunteers with a standard fatty acid composition analysis. We find there are plenty of omega-6 fatty acids in these cell membranes, with about 20% of fatty acids as arachidonic acid and about 10 to 12% as other omega-6 fatty acids. Of course, this high level of arachidonic acid provides a direct link into inflammation and immunity, because the arachidonic acid in the membrane phospholipids can be released when those cells are activated, and the free arachidonic acid acts as a substrate for the cyclooxygenase, lipoxygenase, and cytochrome P450 enzymes, producing these eicosanoid metabolites like the prostaglandins, the leukotrienes, and so on. Now, generally speaking, although this is a simplistic view, these mediators from arachidonic acid, these eicosanoids from arachidonic acid, are mediators of inflammation, they're regulators of inflammation, and they're regulators of immunity. But the simplification is they're often seen to always be pro-inflammatory. Now, mostly they are pro-inflammatory, but that's not always the case. But let's stick with the simple message that these mediators are involved in inflammatory processes, including respiratory inflammation. Now, there have been some examinations of the lipidome in patients with COVID-19, showing alterations in the pattern of eicosanoids that are present, although these seem to be very complicated things that are happening with quite different effects on the eicosanoid lipidome in moderately severe COVID-19 compared to very severe COVID-19. So I think there's a bit more to unravel there. But this is something people are talking about, that while we talk about a cytokine storm, maybe there's also a lipid mediator storm, and I think Charlie will say a little more about that. Now, if we look now at the omega-3 content of these cells, so there's plenty of omega-6 fatty acids. The omega-3 content is rather modest, 2 to 3% of DHA, less than 1% of EPA. But of course, we can change that by giving people omega-3s in food or supplemental form. And this results in a dose-dependent increase in the amounts of EPA and DHA in the cell membranes. This happens to be in neutrophils from healthy volunteers. And the incorporation of EPA and DHA is at the expense of arachidonic acid. So we decrease the amount of substrate that's available to produce the traditional eicosanoid mediators, which are involved in inflammation and regulation of immunity. So this is a sort of a working model where increased exposure to omega-3s alters the composition of cell membranes. This has multiple effects at the level of the membrane, membrane structure, membrane function, the movement of proteins into signaling rafts, the initiation of different signal transduction pathways, the change in the pattern of lipid mediators that are produced. So we're having a different phenotype here, and so we're getting a different inflammatory response, and also in T cells and B cells, a different immune response. So drilling down a little bit more, on the mechanisms of this anti-inflammatory action of omega-3s. I've mentioned replacement of arachidonic acid and membrane phospholipids, so less production of the eicosanoids from arachidonic acid. EPA is a substrate for eicosanoid synthesis. These tend to be quite weak in their action, but EPA and DHA also inhibit arachidonic acid metabolism. I mentioned EPA and more particularly DHA disrupt rafts in the membranes of immune and inflammatory cells, and that seems to be important in terms of interfering with inflammatory signals, particularly those signals that lead to activation of nuclear factor kappa B and the assembly of the inflammasome. Maybe some of this is through activation of PPAR gamma, which is a direct inhibitor of NF kappa B translocation. The end result of all of this is a lower inflammatory tone, if you like, a reduced production of inflammatory cytokines, chemokines, enzymes involved in synthesis of inflammatory mediators and what have you. So the way I like to think of this is a weaker fire of inflammation in the presence of omega-3s compared to in their absence. Now, Charlie's also going to talk about the relatively recent discovery of omega-3 fatty acids, EPA and DHA, but also DPA, as substrates for pro-resolving mediators, the resolvins, protectins, and maresins. And these are really important signals for the turning off of inflammation once it's been initiated. I think these are physiological pro-resolution signals, but they can also be used as therapeutic pro-resolution signals. Now, there's been quite a history of the investigation of these SPMs in respiratory inflammation, often in the context of asthma, but also in the context of acute lung injury. So there are actually many animal studies looking at the protective and therapeutic effects of different resolvins in particular in animal models of acute lung injury, acute respiratory distress syndrome, and other models like sepsis and so on. There are also interesting studies showing that some of these pro-resolving mediators can directly inhibit viral replication, including influenza virus replication, both in vitro, but also in animal models. And this is a really nice paper by Mediator using both the in vitro and the murine models of influenza infection, showing a protective effect of protectin D1. So what I've added on to my scheme here is the generation of the specialized pro-resolving mediators from EPA and DHA, which are the key to the resolution of ongoing inflammation. So again, the way I like to think about this is the fire that's lit in the presence of omega-3s is a weaker fire than in their absence, but the ability to turn off that, to put out that fire, is enhanced in the presence of omega-3s. So we can propose, based on all of that, that EPA and DHA maybe can be useful for either preventing or even treating this hyperinflammatory state, and maybe they also can have a role in preventing or treating the state of immunosuppression, either directly through their own actions or through the production of the specialized pro-resolving mediators. Now, there's a precedent for the clinical application of omega-3s in more severe COVID-19, because in fact they have been used in acute respiratory distress syndrome, both in trials but also in genuine clinical settings for some decades now. And the starting point of this was this paper published in 1999, where an enteral feed, so it's an oral feed that's given through tube feeding that contained fish oil, so EPA and DHA, although DHA is not mentioned in most of the papers, but this is a fish oil preparation, along with gamma-linolenic acid and some antioxidants in patients with severe acute respiratory distress syndrome. And what they showed was within a matter of 4 to 7 days, significant reduction in respiratory inflammation. So infiltration of neutrophils into the lungs was significantly reduced. Lung function improved, so there was better gas exchange. Requirement for mechanical ventilation was reduced. Patients got out of the ICU quicker, and there were fewer new organ failures. So this was the first of several studies using this formulation of fish oil plus gamma-linolenic acid plus antioxidant in ARDS. And other studies followed from that with significant success. Now, just in 2019, we published a systematic review of the use of this formula in ARDS in the Cochrane Library. And this is in the end, I think we included 11 trials, 11 randomized controlled trials of this formula in patients with ARDS. So this is the summary of the outcomes of our Cochrane review. So you see these are all significant findings of that formulation compared with the control formulation without the omega-3s, GLA, and antioxidants, showing a significant reduction in 28-day mortality, a 3-day reduction in length of intensive care unit stay, 2-day reduction in days requiring ventilation, better gas exchange, so airways are working better, and a more than 50% reduction in new organ failure. So I think although this is a mixture of ingredients, one would like to think that it's the omega-3s that are mainly responsible for these clinical benefits. Now, that feed is an enteral feed, so it's given through a tube, maybe directly into the stomach or into the small intestine. Another approach is to provide omega-3 fatty acids intravenously. So we've been involved in a few studies of the intravenous application of fish oil in patients in the ICU. So these are patients who are receiving enteral formula, standard enteral formula, providing them with the energy yielding substrates they need with micronutrients and so on. But in addition, they were given intravenous omega-3s as a sort of a supplement. These are old people in the ICU. So on the left hand here, you see the plasma fatty acid profiles showing that these are the control group. They didn't receive any intravenous lipid. These are those individuals receiving intravenous fish oil, showing changes in the fatty acid levels in the blood, so an increase in EPA, DHA, and total omega-3s, a decrease in omega-6 fatty acids, and a change in ratio of omega-6 to omega-3 and of arachidonic acid to EPA. Now, that's not a surprise, of course. If you're intravenously infusing omega-3s, you should see them in the bloodstream. But on the right-hand side, you see the blood. So this is serum tumor necrosis factor alpha. So this is a pro-inflammatory cytokine, and interleukin-10, which is an anti-inflammatory cytokine in the control group and in the group receiving omega-3s. So the group receiving omega-3s, you get a more, a bigger reduction in the pro-inflammatory TNF, and you get an increase in the anti-inflammatory IL-10. So I think there is a reduction in inflammation in these patients in the ICU receiving intravenous omega-3s. Now, in another study that we were involved in, we looked at clinical outcomes. So these studies actually didn't look at clinical outcome, but we looked at clinical outcome in this study, showing that patients, these are septic patients in the ICU who couldn't receive enteral nutrition. They were intolerant to enteral nutrition. They got all of their nutrition intravenously. If fish oil was included in that intravenous nutrition, there was an improvement in respiratory function by day 6, and there was a reduction in hospital length of stay that was quite remarkable. Now, there have been quite a few of these studies of intravenous omega-3, intravenous fish oil administration in ICU patients. And these are 4 meta-analyses that were published between 2012 and 2015 that I summarized in this review of 2019. Now, these are the clinical outcomes: infections, length of ICU stay, length of hospital stay, need for ventilation, and mortality. And these are the effects that were identified in each of those meta-analyses. And you see all meta-analyses indicate an improvement. So reduced infection, shorter ICU stay, shorter hospital stay, less need for ventilation, and lowered mortality, although these effects are not always statistically significant, partly because often these are very heterogeneous patients, and also the number of studies that have been done are quite small. But I think overall, this is encouraging. So if you think about these studies in ICU patients and patients with ARDS, maybe EPA and DHA have a role in reducing adverse outcome from severe COVID-19. So maybe we can use omega-3s to treat COVID-19. And quite a number of clinical trials have been registered to test whether EPA and DHA can be used to treat COVID-19. Some of these are trials with oral supplements. Some of them are trials with intravenous omega-3s. And of course, we await the findings of those trials. I think another question is whether omega-3s reduce the risk of COVID-19, whether they reduce the risk of respiratory infection. So can they have a preventative effect? I think I've made a reasonable case that they might have a therapeutic effect, but can they have a preventative effect? Now, in fact, quite surprisingly, there aren't a lot of studies on omega-3s and risk of respiratory infection in the way that there are plenty of studies on vitamin D and even some studies on vitamin E, but there aren't so many with omega-3s. Now, this is a trial that we did in school children in Thailand, aged 9 to 12, and they consumed a milk that was fortified with omega-3s, giving them 200 milligrams of EPA and 1 gram of DHA daily, 5 days a week for 6 months. And the placebo group had the same milk, but it was fortified with a vegetable oil without EPA and DHA. And the school children consuming the fish oil fortified milk were less likely to get ill. This was mainly respiratory illness. So the over 6 months, the proportion of children who got ill was lower if they received fish oil, and the number of sick days per ill subject was decreased by 50% with fish oil compared to placebo. So this is a hint that omega-3s maybe reduce the risk of respiratory illness, and they also reduce the severity with fewer sick days. So what I've told you is that eicosanoids produced from arachidonic acid are mediators and regulators of inflammation and immunity. I mentioned these studies looking at the lipidome of COVID-19, where they report alterations in blood eicosanoids, although the pattern actually isn't that clear. I've told you that omega-3s, that is EPA and DHA, exert multiple anti-inflammatory actions. Importantly, they're substrates for synthesis of specialized pro-inflammatory mediators, resolvins, protectins, and maresins. Those mediators are effective in animal models of lung injury and other hyperinflammatory states. There's clinical data and actually commercially available products that for enteral feeding with EPA and DHA in patients with ARDS, where the trials show improved respiratory function, reduced need for ventilation, and fewer organ failures and death. I showed you the Cochrane review. And also I mentioned the intravenous route, which can deliver EPA and DHA quickly and in high amounts and reduces inflammation. And this might have clinical benefits. And again, I mentioned the 4 meta-analyses of intravenous omega-3s in patients in the ICU. So I think EPA and DHA have a role, may have a role in reducing risk of COVID-19 becoming more severe. They may have a role in treating severe COVID-19 the way they can treat ARDS, but it's not really clear whether they have this effect in terms of preventing infection, that is helping the immune system deal with the early stages of infection so that the virus is cleared. My last slide is just to give you a hint that that might happen, although there are many limitations to this study, which is in press at the moment in BMJ, Nutrition, Prevention and Health. This is using data from almost 500,000 people who are using, it's called the COVID-19 Symptom Study app. And in the course of putting stuff into the app, people have been recording their use of supplements. So in the graph here is the odds ratio for testing positive for SARS-CoV-2 in those taking omega-3 supplements compared to those not using supplements in the United Kingdom, the United States, and Sweden. So you see overall in all three countries, those using omega-3 supplements had a lower risk of having a COVID positive test compared to those not using omega-3 supplements. This seemed to be, especially in women in the UK and the US, and in men in Sweden. That might be to do with numbers. It might be to do with the fact that men and women in those countries behave differently. So I think this is encouraging data, but we need more sort of robust observations to know whether omega-3s can actually prevent SARS-CoV-2. Thanks very much for your attention. I'll finish my presentation there.
Okay, as co-chair of this session, I'd like to thank Phil for that wonderful introduction, but also a beautiful first presentation of the session and some provocative comments, data at the end as well. We have some time for some quick questions. You can post these questions on text, the questions, and you can do that for all the speakers as we go through the session. But while we're waiting for questions to come through, Phil, we have time for a couple. I've got a couple of questions. I'd like to begin by going at a mechanistic level. When you look at the way immune cells respond to an infection, they change shape, their composition significantly. If you're looking at the effects of fatty acids, eicosanoids in this setting, is there a big difference if we take like a resting T cell versus an activated T cell? I mean, are you getting a very different picture if you look at cells in different settings?
Yeah, that's a great question. So if you stimulate T cells in vitro, they change their fatty acid composition. That actually was demonstrated over 20 years ago, and we published papers on that. Now, at the moment, we actually have a grant to look at this change in fatty acid composition in stimulated T cells. And also, I'm guessing that other immune cells also change their composition. Part of this is because all of these cells have very functional membrane capabilities. So I think they're trying to modify their membrane to sort of optimize their function. Of course, they're using fatty acids and other lipids for signaling activities. So they're sort of depleting some pools and topping them up as the cells are activated. So I think you're right. If you study cells at different stages in patients, for example, you may get different readouts.
Yeah, I'm guessing that's true. But if you look at cells like dendritic cells, they change their shape so much as they become activated. My second question is more to do with the trials aspect in the context of COVID-19. In terms of the efficacy of things like eicosanoids, do you see big age differences? I mean, age is one of the major drivers of mortality in diseases like COVID-19. Is this something which is better if you're older or worse? Or
maybe Charlie is a better person to ask that. I'm not familiar with the literature on age and eicosanoid production. There are some papers looking at age and the specialized pro-resolving mediator production, but I don't think they're very clear. But maybe Charlie can comment on that. But I think that's a really good point. That, aging also is associated with differences in fatty acid composition of cell membranes, for example. Obesity, which is another risk factor, also associated with differences in fatty acid composition.
Okay, I'm just going to ask you one final question because we have got a question on the board.
Oh, yeah.
And it's from Elaine S. Krull, who says, want data to suggest a reduction in clots with W3S.
Oh, yeah. One of the other effects of omega-3s is reduction in platelet aggregation and thrombus formation. So I think omega-3s do have a role in preventing clotting. Whether that's useful in the context of the possible, I mean, maybe Bill's going to talk about this, the coagulation issues of both COVID-19 and COVID-19 vaccination. I think that's, I mean, it's a good question in that context, for sure.
Indeed. Well, there are more questions coming through, but in the interest of time, I'm going to say thank you again, Phil, and we'll move on to our second speaker in this session, who's